Hello, everyone. My name is Ahmed. I'm a third year pathology resident, and today I'm going to be talking about the interpretation of flow cytometry in acute myeloid leukemia. So let's get started. So first of all, the most important plot to look at in acute leukemia cases is the CD45 against side scatter plot. And by doing this, we can identify this population here in red. The gate in red is called the blast gate because most blasts tend to be located in this location. Here in green, we see the lymphocytes. The lymphocytes have brighter CD45 expression. To the right of the lymphocytes, we have in yellow monocytes. Monocytes tend to have brighter CD45 expression compared to lymphocytes, and they tend to have higher side scatter compared to regular blasts. And lastly, in blue here, we have the granulocytes, and granulocytes tend to have a higher side scatter because of their complexity, the granules that they have, and other features. So that's the first thing that we look at. But just be careful, not all blasts fall in the blast gate. And in addition to that, not all cells that are identified in the blast gate are blasts because basophils can fall here, plasmacytoid dendritic cells can fall here, hypogranular myeloid cells can fall here. Immature monocytes sometimes can have a dimmer CD45 expression, and because of that, they can fall here. Neoplastic plasma cells can fall here. Erythroid precursors in general are CD45 negative, but sometimes they can fall here in this gate as well, and degenerating cells can fall here as well. That's why we need flow cytometry, and that's why we have to use panels that would help us to identify this population as true blast population, first of all. And then if it's a true blast population, then to classify this blast population as acute myeloid leukemia or B lymphoblastic leukemia lymphoma or T lymphoblastic leukemia lymphoma or mixed phenotype acute leukemia and so on and so forth. So with that knowledge in mind, let's look at some examples. So first here in this bone marrow, as you can see here in maroon or brown, we have our dim CD45 blast population is pretty expanded. We do have some lymphocytes here in green, very few monocytes here in yellow, and very few granulocytes here in blue. And here it says the dim CD45 population is about 95% of the population of cells that we have here. However, you should not be using flow cytometry to quantify the blast percentage for a lot of reasons that I'm going to mention in a separate video. But for now, this expanded population here is a dim CD45 population. So we said we need flow cytometry to establish that these are blasts, first of all. And then secondly, if these are blasts and we have an expanded population, we need to identify this blast population as myeloblasts or lymphoblasts or whatever. So since I'm talking about acute myeloid leukemia, I'm going to say that generally speaking, there are immature hematopoietic markers, and these are dim CD45 expression and CD34 expression. These would not tell you whether these are myeloblasts or lymphoblasts, but these are markers that would tell you that these are immature hematopoietic cells. However, be careful, not all blasts are CD34 positive. For myeloid blasts in general, CD117 is an immature marker. And then mature markers for myeloid cells in general that would help you to classify these blasts are as myeloid blasts include CD13, CD33, CD11B, CD15, CD65, and other markers. Also, one of the most important markers, which is considered a defining lineage marker for myeloid blasts, the MPO. So that's an important marker to remember. And then in addition to that, myeloid blasts and monoblasts, they share common antigens like CD13, CD33, and CD11B, for example. But there are more specific markers for monoblasts, and these include CD11C, CD14, and CD64, And then by immunohistochemistry, you can use lysozyme. So let's look at this blast population. Let's look at this dim CD45 population here that we have, and let's see what's going on. So here in this panel, we see CD2, CD3, CD5, and CD7. And first of all, how do we decide whether a population is positive for a specific marker or negative for a specific marker? So for example, let's look at this box here in the top left corner. Here on the y-axis, we have CD34, and here on the x-axis, we have CD2. So this horizontal line here will divide the populations of cells that we have as CD34 positive above the line and CD34 negative below the line. So anything that is above this horizontal line is going to be positive for the marker that is here indicated on the y-axis. As for the x-axis here, we do have CD2. Anything to the right of this vertical line is going to be positive for CD2, and anything to the left of this line is going to be considered negative for CD2. So this green population here is positive for CD2, and this blue population and this brown population here is going to be negative for CD2. If you have a population that falls here in the middle, like this population here on the top right corner for CD7, so CD7, anything on the right of this vertical line is going to be considered CD7 positive. Anything on the left here is going to be considered CD7 negative. If you have something here in the middle of the line, some people would call that dim. Some people would call that partial. And some people use the terms dim and partial interchangeably. However, there is no actual definition for dim and there is no actual definition for partial. And some people would consider calling dim if you have something that is spanning two boxes like this one here in the middle, and would consider partial if you have a separate population here and a separate population here, and there is no connection between both of them. However, there are no specific criteria to call that. So just follow whatever you follow in your institution, because this would be important for following up patients when they come after treating their leukemia. So with that in mind, we have our population here. It's CD34 positive because all the cells fall above this horizontal line here. So we have a dim CD45 population that is CD34 positive. This population is negative for CD2. This population is negative for CD3. This population is negative for CD5. And this population is dim for CD7. CD2, CD3, CD5, and CD7 are T cell markers. So if your blast population expresses these markers, then you should consider a T lymphoblast population. The most specific marker for T cell lineage is cytoplasmic CD3, followed by surface CD3, and CD7 is a common marker that is expressed in T lymphoblasts. However, as you can see here, our CD3 is negative, CD2 is negative, CD5 is negative, and CD7 is dim. You have to remember that acute myeloid leukemia may aberrantly express lymphoid markers, and lymphoblastic leukemias may aberrantly express myeloid markers as well. That's why we need a combination of multiple markers in order to establish the lineage of a specific leukemia case. And that's why it's always important to look at the general picture, looking at the morphology, looking at flow cytometry, and looking at multiple markers, and then looking at the cytogenetic and molecular tests as well. Also, this CD7 dim population, or if you have any positivity for a marker like CD7, that would also help you to establish that this blast population is not a normal myeloid blast population, because normal myeloid blasts would never express CD7. And that would be helpful in following up with patients with leukemia. If this patient gets treated, for example, and then sometime in the future, they get a bone marrow core biopsy, and then they send flow cytometry for that sample as well. If you have a myeloid blast population about 3%, which is not really elevated, And then in that setting, it becomes really hard to differentiate whether these blasts are just regenerating blasts of the transplanted bone marrow, for example, or if this is like a recurrence for the acute myeloid leukemia that the patient had. And what would be helpful in that setting is looking at the expressed markers. So if that leukemia, for example, is CT7, you would know that this is an abnormal myeloid blast population, especially if the acute leukemia case that the patient already had before in the past was CT7 positive. And that's why aberrant expression of markers is really helpful in following up with patients with acute leukemia in general. How do we draw these lines, like this line here and this line here? We use internal control. For example, this green population here is our T lymphocyte population. T lymphocytes are normally CD2 positive. This population here is granulocytes, and granulocytes are negative for CD2 normally. So you would draw the line in the middle between this positive control and this negative control. If you have only one positive control and you don't have a negative control, or if you have a negative control and you don't have a positive control, like for example, let's assume that we don't have this blue population here, and you do have this green population, and for sure we know that this is a T lymphocyte population because it's CD2 positive. Anything to the left of this population is going to be considered negative. But if you have like a positive control, internal positive control, and internal negative control, then you can just draw the line in the middle. And that's how we draw the lines. And then after that, we come up with this box here that is cleaner. And here we're just looking at the abnormal population that we have. So our population here is negative for CD2, CD3, CD5, CD7 shows dim suppression. Let's go here. CD56 is positive. So normal myeloid blasts are not CD56 positive. So this CD56 positivity is going to tell you that you're dealing with an abnormal myeloid blast population, and that can be helpful in following up with this patient. Our blast population is negative for CD19, and CD19 is a sensitive and specific marker for B lymphoid differentiation. So we're not dealing with a B lymphoblast here because it's CD19 negative. However, very rare cases of B lymphoblastic leukemia, lymphoma with CD19 negativity have been reported. But for the purpose of this video, this population here is completely CD19 negative. It's not a B lymphoblast population, but we're going to look at additional markers in order to confirm that. Here again, CD7 dimly expressed, CD19 is negative. And then we go here, these are just control plots. And here we do have a couple of lymphoid markers. We do have CD10. CD10 is expressed in immature B lymphoblasts. This population is CD10 negative. CD19 is negative. CD20 is a B lymphoid marker. CD20 is negative. CD38 here is dim. CD38 is not specific for T lymphoblasts or for B lymphoblasts or for myeloid blasts at all, but it's helpful in following up with patients. And CD38 is a marker of immaturity in general. So our population here is negative for B lymphoid markers, including CD19, CD20, and CD10. So it's not a B lymphoblast population. And we already said that CD2, 3, 5, and 3, 2, 3, and 5 are negative, so it's not a T lymphoblast population. Now here, this is CD33. CD33 is bright. And we use the term bright when you have the population all the way close to the end of the box. Like this CD33 population here, it's almost hitting the wall here. So this is a bright CD33 expression. CD33 is a myeloid marker. Additional myeloid markers include CD13 and CD117. CD117 is an immature myeloid marker. CD13 and 33 are more on the mature side. Additional markers include CD11b, CD15, CD65, and myeloperoxidase. And to call an acute myeloid leukemia, you need at least 2 myeloid markers. Preferably, you need myeloperoxidase MPO expression. So here we do have CD33 expression. We do have CD117 expression. CD13 is negative. So let's continue looking at these plots. CD123 is positive here. And then CD123 is positive in about 99.5% of the abnormal blasts that we have. And this is helpful because we have targeted therapy against CD123. So whenever you report CD123, give a percentage for how many of the abnormal blasts are positive. HLA-DR is not a specific marker. It's seen in immature cells as well as additional cells like plasmacytoidendritic cells as well. Here, HLA-DR, I'd call it dim, and CD7 is dim. Here again, CD13 is negative, CD33 we said it's bright, CD117 is positive, HLA-DR is dim, CD7 is dim, and CD123 is positive in over 99% of the blasts. Now here we do have our monocytic tube, and then CD11B is dim. CD11B can be expressed on monoblasts or myeloid blasts. And here CD11B is dim because the population is in the here spanning these two boxes. And it seems like one population. CD14 is a very helpful monocytic marker. However, it can be lost in immature monocytic cells like monoblasts. This here population is completely CD14 negative. CD64 positivity is seen in monoblasts as well, especially if it's bright expression here. Our CD64 is dim, and CD4 can be expressed on monocytic cells as well as CD4 is negative. And to call like monocytic differentiation, you need at least two markers. I'm not really convinced that there's any monocytic immunophenotype here because 11B is dim, and 11B is not actually very specific for monocytes. CD14 is completely negative, and then CD64 is dim, and CD4 is completely negative. And here for comparison, it's not projecting well because we do have very few cells, but these are monocytes. They are CD11B positive here. There's CD14 positive here and here as well. And they are CD64 positive because they are above this line here. And that's how we drew these lines by comparing these cells that we have to the normal monocytes that we have. Maybe for this line here, I'd probably draw the line higher, like here, because the monocytes end here, and anything below this line should be considered negative. Here, more of the monocytic markers. You can see 4 is negative, 33 is bright, 14 is negative, C33 is bright. And lastly here, MPO, I'd call it dim, and TDT is an immature lymphoid marker. It doesn't differentiate T lymphoblasts from B lymphoblasts, but is very good for lymphoblasts in general compared to myeloblasts. So TDT is negative. CD79A is a good marker for B cell differentiation, and CD79A is negative. Myeloid peroxidase is dim in our case. So the summary, we do have this abnormal myeloid blast population, dim CD45, CD34 positive. These two markers are markers of immaturity in hematopoietic cells in general. Then our blast population was CD117 positive. This is an immature myeloid blast marker. And then our population was negative for a couple of myeloid markers, including CD13, CD33, as well as CD11B, and as well as dim expression of myeloperoxidase. T lymphoid markers, TDT, which is an immature lymphoid marker in general, was negative. And then CD2, CD3, and CD5 were negative. In that case, here we do have cytoplasmic CD3, which is the most specific marker for T cell differentiation, is negative as well. So it's not a T lymphoblast population. And then B cell differentiation markers like CD19, CD20, CD79A, as well as CD10, they were all negative. So there's no evidence of B cell differentiation. So putting all these findings together, the findings support an acute myeloid leukemia. So this is a general example. Now let's look at specific cases. Here we do have a case of This patient, 45-year-old, presented with shortness of breath and then was found to have circulating blasts in the peripheral blood. And because of that, they sent for flow cytometry. So here, as you can see, in green, we do have our lymphocyte population. In yellow, we don't have a lot of monocytes, very few monocytes. And then it's kind of hard to separate this red population from this blue population. It almost looks like it's one population extending all the way here from the dim CD45 side, which is approximately here, all the way to the blue side here, which is the granulocytes. But as you can see, dim CD45 population usually follows here. But what was called the dim CD45 population here is not actually very dim, or it might be dim for CD45, but the side scatter for this population is higher than what we normally expect for our blast gate. So we do have a dim CD45 expression that has less expression compared to lymphocytes as well as monocytes, very close to the granulocytes, but it has higher side scatter compared to the normal blasts that we can identify in the blast gate. So let's check. Let's confirm if these are blasts first of all, and then if these are blasts, then what's the phenotype? So interestingly, I'm going to look at this line here, these boxes. Interestingly, this population is negative for CD34 since all these cells fall below this line. CD2 is negative, CD3 is negative, CD5 is negative, and CD7 is negative. So we do have a dim CD45 population that is negative for CD34 and negative for the T lymphoid markers, including CD2, CD3, CD5, as well as CD7. Here, CD19 is dim. We see dim expression because the line is in the middle. And then here, CD56 is negative in this population. So we cannot use CD7 and CD56 in order to follow up this patient and to see if this patient has residual disease after therapy. But we can use other tools for that. Here, our B cell tube, our abnormal population is CD10 negative. CD19 is dim, as we previously mentioned. CD20 is predominantly negative, but you can call it dim. And CD38, I would call it dim as well. And here our myeloid tube, CH33 is bright, C13 is positive, and CD117 is positive. And we said CD117 is a marker of immature myeloid cells. C13 and C33 are both myeloid associated antigens. HLA-DR is negative as well. So we do have this abnormal population that is CD34 negative, HLA-DR negative, but it's positive for a couple of myeloid markers, including CD117, CD13, and CD33. CD123 is positive in this population. CD7 is negative. And here our monocytic tube, this population is negative for CD11b, negative for CD14. It's negative for CD16 as well. CD16 is a granulocytic marker and it's expressed on NK cells. So this green population here is our NK cell population. That's why we drew the line here. CD14, which is a good monocytic marker, is negative. CD64 is a granulocytic as well as monocytic marker. As you can see, the blue in the background is our granulocytes and the red is our abnormal population here, CD64 positive. CD4 is predominantly negative, or we can say dim expression. So we don't have a lot of expression of monocytic markers. So these are not monoblasts. And lastly here, MPO is positive, and we said MPO is the most specific myeloid lineage marker. TDT, which is an immature lymphoid marker, is negative, and CD79A is negative, and cytoplasmic CD3 here is negative. So it seems like we're dealing with an acute myeloid leukemia because we do have expression of CD117. We do have expression CD13, CD33, CD11b, CD64. So we see expression of a couple of myeloid antigens, including myeloid peroxidase, which is the myeloid lineage defining marker. We don't see any expression of monocytic markers. T lymphoblast markers, including TDT, as well as others like CD2, 3, 5, and 7, were all negative. And of the B lymphoid markers, CD19 was dim and the others were negative as well. So it seems like we're dealing with an acute myeloid leukemia. But this myeloid leukemia is characterized by CD34 negativity, HLA-DR negativity, and higher site scatter and CD64 positivity. Putting all these findings together, this is highly suspicious for acute promyelocytic leukemia with PML-BRARA fusion. And this type of acute myeloid leukemia is debilitating and can cause to sudden death due to disseminated intravascular coagulation. However, this diagnosis is not a diagnosis that you make on flow cytometry. It's predominantly a morphologic diagnosis, and then you do the detection of PML-BRAR fusion. If the fusion is positive, then you have the case. But if you have a flow like this and the morphology, you're not quite sure if it's acute promyelocytic leukemia or not, this immunophenotype is very good for acute promyelocytic leukemia, namely the negativity for CD34 and HLA-DR, the higher side scatter, the bright CD33 expression, as well as the positivity of CD64. CD64 is almost always positive in acute promyelocytic leukemia. So this is an example of APL. Now, let's look at another example. We have this example here, our dim CD45 population in red, lymphocytes in green, monocytes in yellow, and granulocytes here in blue. First of all, let's see this population is negative for CD34. It's negative for CD2, CD3, CD5, and CD7. So it's negative for T lymphoid markers. CD19, which is a B lymphoid marker, is negative. CD56 is negative in this blast population as well. So for now, I cannot decide what type of population I'm dealing with. So far, CD19 is negative, CD10 is negative, and CD20 is negative. So it's not a B lymphoblast population. CD38 is positive, and CD38 would just tell you that this is an immature population. So it's not a B lymphoblast population, and it's not a T lymphoblast population so far. Our myeloid area here, CD33 is bright, CD13 is positive, CD117 is positive, and this is started to look at the last case that we looked at of acute promyelocytic leukemia with PML-BRAF fusion. However, HLA-DR here is predominantly positive. About 70% of these cells are positive. So, yeah, that's how it's different from acute promyelocytic leukemia with PML-BRAF fusion. C123 is positive in almost all of the abnormal cells. C7 is negative here. Now let's look at our monocytic tube. Our red population here, abnormal population, is negative for CD11b, negative for CD14 because it's below this horizontal line. It's negative for CD16, negative here for CD14 because it's to the left of this vertical line. It's, I'd say, dim for CD64 because some of the cells are negative, some of the cells are positive, and CD4 here is negative in this population. So I don't see any expression of monocytic markers. Here, more emphasis, C16 negative, 4 negative, 14 is negative, 11b is negative, and C64 is dim in this population. And lastly here, myeloperoxidase here is positive, which is the myeloid defining lineage marker. TDT, which is an immature lymphoid marker, is negative. C79A, which is expressed in B lymphoblasts. And some cases of T lymphoblastic leukemia is negative here as well. And cytoplasmic CD3 is negative. So overall, we're dealing with this abnormal myeloid blast population that is dim CD45. Interestingly, it was CD34 negative, and that's why we don't use the percentage of CD34 positive cells to quantify the percentage of blasts in the bone marrow because not all blasts are CD34 positive. We do have cases where the myeloid blasts are CD34 negative, or blasts in general can be CD34 negative. However, we see expression of a couple of myeloid markers, including CD117, CD13, CD33, and myeloperoxidase. So we're dealing with an acute myeloid leukemia. This turned out to be an acute myeloid leukemia with NPM1 mutation. And This type of leukemia sometimes can show morphological features similar to AML with PML RARA fusion, and sometimes it can show flow cytometric findings also similar to acute promyelocytic leukemia with PML RARA fusion. It can be CD34 and HLA-DR negative sometimes, and that's why we never make the diagnosis of acute promyelocytic leukemia with PML RARA fusion on flow cytometry. Now, this is our last example for today. We do have this TIM CD45 population. Here in blue, granulocytes, in yellow, monocytes, and here in green, we have lymphocytes. And this brown with background red population here is our DIM CD45 population. This population is positive for CD34 because all the cells are above this line here. It's negative for CD2, CD3, CD5, and CD7. CD19 is dim in this population, and CD56 I'd call it partial because it seems like we have one population here and a separate population here. This population is C19 dim, C10 I'd call it dim as well, C20 is negative in this population, C38 is bright in this population. And here our population is positive for CD13, CD33, and CD117. So it seems like we're dealing with a myeloid blast population. HLA-DR is positive in these cells, and CD123 is positive in about 97% of the cells. So that's important for treatment. Now let me take you to our monocytic tube. C11b is negative, C14 is negative, C64 is positive in this population. Here more, C16 is negative, 64 is positive, 11b is negative. C4 is predominantly negative in this population. So it doesn't seem like we're dealing with a monoblast population. And here MPO is predominantly positive, about 67%. So I'd call that predominantly positive. TDT here in this example, it seems like TDT is positive as well. So that's really interesting. However, CD79A is negative in this population. So overall, we do have an immature blast population that is positive for CD34, positive for CD117, positive for CD13, positive for CD33, and additional myeloid markers like CD64. Putting all these findings together, it seems like we're dealing with a myeloid blast population. However, it shows dim expression of CD19 and positive expression for TDT. And the message here is that lymphoid markers may aberrantly be expressed on acute myeloid leukemia. So don't forget that. And that's important for follow-up of these patients. The last thing that I want to discuss today here, these are acute myeloid leukemia with defined genetic abnormalities. I'm just going to share a couple of important things. Here, acute myeloid leukemia with PML RARA fusion tends to have high forward and side scatter, CD34 and HLA-DR negativity. CD2 is positive in about 10% of the cases, and these cases they have frequent association with the microgranular variant of acute promyelocytic leukemia. Acute myeloid leukemia with RUNX1, RUNX1T1 fusion tend to have bright CD34 expression. CD33 is usually negative, and aberrant lymphoid marker suppression is frequently seen in this entity. But what I want to highlight is that CD56 is positive in some cases, and it's associated with worse prognosis in these patients. For acute myeloid leukemia with CBFB MY11 fusion, sometimes you can see two blast populations. One of them is an aberrant, is a DIM CD45 population, positive for CD34, 117, 13, and myeloid peroxidase. So that's our typical myeloid blast population. But they can also have sometimes a more mature monocytic CD45 bright population expressing monocytic antigens like CD14 and CD64, lysozyme by immunohistochemistry, in addition to myeloid markers, but tend to lack BCA34 as well as CD117 expression. As for acute myeloid leukemia with RBM15 MRTFA fusion, this can have an acute megakaryoblast leukemia morphology, and because of that, they can express megakaryoblast markers or platelet glycoproteins like CD41, CD61, and CD42B. But be careful because normal platelets can sometimes adhere to normal blasts like myeloid blasts or lymphoid blasts. And because of that, they can express these markers. So you have to be extra careful. And just remember that you have to use the morphology in addition to flow cytometry, not just flow cytometry. Acute megakaryoblast leukemia, the blast can be positive for myeloid markers like CD13 and 33, and other markers like CD34 and HLA-DR can be negative. And because megakaryblasts in general are very big, they tend to have high forward scatter. Here, acute myeloid leukemia with MECOMP rearrangement, they can have frequent aberrant CD7 expression, but that's not something that you can use to make a diagnosis. For acute myeloid leukemia with NUP98 rearrangement, just remember that these cases can be like acute myeloid leukemia, typical C34, 117 positive, 1330 HLA-DR, myeloid peroxidase positive. However, they can have monocytic presentation, in which case they can suppress monocytic markers like CD14, CD64, CD11C, and lysozyme by immunohistochemistry. They can also present sometimes as megakaryoblast leukemia, in which they can suppress CD41 or CD61 or CD42B. And they can sometimes present as acute erythroid leukemia, in which CD71 and EC adherent can be expressed on the blasts. As for acute myeloid leukemia with NPM1 mutations, most cases, about 80% are CD34 negative. However, immunophenotypic categories include we have three categories, one of which is predominance of immature myeloid blasts that can be either CD34 positive or negative, with positivity of CD117 and HLA-DR. However, they can have an acute promyelocytic leukemia-like features with a similar immunophenotype, so just be careful. And sometimes they can show predominance of myelomonocytic or monocytic differentiation. As for the last five entities here in this table, the most important one is AML with CABFA2T3 GLIS2 fusion in terms of flow cytometric findings, because over 50% of the cases, they show what's called the RAM phenotype, which is strong CD56 expression, lack of HLA-DR expression, and under-expression of CD45 and CD38. These tend to be associated with worse prognosis. And lastly here, for acute myeloid leukemia with MNX1 ETV6 fusion, it may express T-cell markers in addition to myeloid markers. This is the end of this video, and see you next time.